Well, good evening, friends, and welcome to this June edition of Glaucoma Australia's live Q&A, proudly supported by our long-standing and very generous friends at Glaucos. My name's Adam Check, and I am honoured to be leading the Glaucoma Australia team as its Chief Executive. And before I introduce your guest speaker this evening, I would like to take a moment to acknowledge the traditional custodians of the lands, the skies, and the seas in which we collectively gather for tonight's Q&A. I'm currently on Darug country, and so I pay my respects to elders past and present, and of course along with their emerging leaders. Now, tonight's Q&A topic is testing in glaucoma, what and why. And our presenting guest speaker is someone that I have the privilege of working with each day, being one of two senior orthoptist patient educators that Glaucoma Australia is lucky to have. Valerie, or Val as I know her, joined Glaucoma Australia in April 2024, having enjoyed an extensive career spanning private orthoptic practice, disability services, rehabilitation, education, low vision and clinical research. As a former associate lecturer at the University of Sydney in orthoptics and a mentor for clinical orthoptic students, Val has played a significant role in shaping the next generation of professionals in this field, your field. Val has additionally served on both the federal and state councils of Orthoptics Australia from 1993 to 2012, in which she later received the distinguished honour of Orthoptics Australia Fellow in 2007. So please welcome Val. And Val, the floor is all yours.
Thank you, Adam. And I'd just like to say thank you to everyone for joining this evening. As Adam mentioned, it's in-clinic test what and why. And why did I choose this for the topic of tonight's webinar? Well, being new to Glaucoma Australia, I'm involved in responding to patient questions and comments on a daily basis. And these questions obviously are all around glaucoma. And I've learnt that Glaucoma Australia's site-wise program and our orthoptist educators are the gap fillers in between patient appointments. We field the questions surrounding all things glaucoma, and we absolutely love it. There's no such thing as a silly question, and we welcome every question that you bring to us. Just winding back, I'm sure that you know a lot of this already, but glaucoma is regarded as the silent thief of sight. It's the name given to a group of eye diseases where vision is lost due to damage to the optic nerve. And the optic nerve is the nerve that travels from the back of the brain and joins up to the back of the eyeball. That nerve has retinal nerve fibers and retinal cells, and they carry all of the visual information from the back of the eye to the brain. So when you start to get damage to those nerve fibers and changes to those cells, that's glaucoma. We also know that in a number of the glaucomas, you have a buildup of fluid or pressure at the front of the eye, and that causes damage to the back of the eye. And just some fun facts about glaucoma. 1 in 50 Australians will develop glaucoma in their lifetime. 50% of people with glaucoma don't know that they even have it, and you're 10 times more likely to develop glaucoma if you have a direct relative with glaucoma. So there are many different types of glaucoma, and the variation is due to such things as age of onset, family history, lifestyle, anatomical makeup of your eye. However, regardless of the type of glaucoma that you have, your optometrist or ophthalmologist will be checking the same areas of your eyes for either confirmation of the disease or for monitoring of its progress. And you can see in red the eye parts that are involved in glaucoma, and they're actually common to a lot of the glaucomas. So when they're checking your eye, what parts of the eye are being checked? And where are they? We know that the fluid is produced at the front of the eye, and it also drains at the front of the eye in a little location called the angle. However, at the back of the eye is where the changes or the damage takes place, and the precise mechanism of that interaction isn't actually clear. So in order to determine if someone is a suspect or if they have glaucoma, the optometrist or ophthalmologist will perform a number of tests. And there are a few main tests that will be very familiar to everyone here this evening. I'm presenting these tests in no particular order. And each time you go and have your eyes checked, there may be additional checks such as measuring your visual acuity. That will also be done routinely. So what do each of these tests tell us? Well, I'm going to break these down, so please bear with me. So there are telltale signs or hallmarks that your clinician is looking for, and they will use these common tests in order to find those hallmarks. The results of each of these tests on their own are a piece of the glaucoma jigsaw, and when you join those results together, that will determine your glaucoma status. So it's not only a photo or only a scan or only the pressure. You need to jigsaw them together to determine if you have glaucoma and where your glaucoma is up to. In photography, they're documenting the look of the back of the eye. So it's creating a picture of what's happening at that point in time. A photo also provides quantitative information about different parts of the back of the eye, the cup, the neuroretinal rim, and the contour of the nerve fiber layer. And I'll explain those a little bit further later. And you can also look at the front of the eye and document what's going on there with glaucoma. If you have an OCT scan, that stands for very long words, ocular coherence tomography, that creates a computerized image of the back of the eye. And it can assess the integrity or thickness of the nerve fiber layer, the layer that's carrying all the messages through the nerve to the back of the brain. It can also look at the drainage area, the angle at the front of the eye. And if you've had treatment, such as a stent or a drainage device, even that can be shown on an OCT. Integral is measuring the pressure of the eye, the internal pressure, and that lets us know about the stability of your pressure, which often in some forms of glaucoma can lead to the damage at the back of the eye. They'll also use different instruments like a slit lamp. That's the one where you put your chin on the chin rest, forehead against the bar, and you look straight ahead with the ophthalmologist on the opposite side of that machine. And they're looking at the front surface of the eye and around the pupil. And the clinician's taking their own mental photo of what's going on in your eye. And sometimes they'll hold up magnifying lenses just to check the drainage area. And they'll also look at the back of the eye if they have other instruments that they might hold up. And again, that's allowing them a subjective photo. The visual field test, I'm sure everyone knows the visual field test. That's plotting each eye to see if there are any changes to your field of vision, especially off to the side. And it can give us more of an idea about progression of loss. Now, these tests can vary from clinic to clinic. Some machines are fancier in what they measure compared to other ones. But we need to combine each of these tests together to determine if you have any hallmarks of glaucoma and what the status or progression is. So now we know what they're looking for, what instruments they're using. When you look at the back of the eye, this is what the doctor's typically wanting to look at. The nerve joins the back of the eye, and when you look inside the eye, you can see the optic disc. That's that blue circle there. In the middle of the blue circle is a green circle. That's the optic cup. And I'm going to call the residual area between those two It's called the neuroretinal rim, but I'm just going to refer to it as the donut throughout this presentation. Now, if there are any changes at the back of the eye, what are some of those typical things that they might see? So in the first two pictures there on the left, the A and the C, you can see that the middle circle is quite small compared to the outer circle. So the cup in the middle is at a nice ratio overall to the whole disc. In the lower one, you can see that that cup in the middle is bigger. So it's a higher cup to disc ratio. That's very typical of glaucoma. And if that ratio is more than 0.5, it confirms the presence of glaucoma. If you have progressive glaucoma, you can have a change in the shape of that middle disc. And in this one, it's elongated. And it elongates because there's been damage to all those little nerve fibers carrying the message to the back of the brain. You can also have asymmetry between the two eyes in that cup to disc ratio. If that asymmetry is more than 0.2, that's indicative of glaucoma as well. The laminar dot sign is for very advanced glaucoma, and it's where some of the little supportive network that the nerve fibers go through, the pressure sort of crushes that, and the nerve fibers get crushed, the blood vessels get crushed, and you have quite an advanced glaucomatous state for that one. Also, looking at the back of the eye, you might notice particular hemorrhages that are particular for glaucoma. Some of the blood vessels might be an odd shape. They might look a bit kinked, still in this same disc cup area. The blood vessels might have moved place with advanced glaucoma, and that donut shape can change colour over time. You can also notice and have evidence of previous surgery that's happened to the front of the eye. You may have had some laser, and there's a sequence of dots that you can see there where they've lasered the iris, the coloured part, to allow more space around the drainage section of the eye. Or it might just be a single laser dot that they have made to create an extra drainage hole at the front of the eye. If you've had surgery for your glaucoma, you may notice, well, the photographer may notice under your top eyelid might be like a little blister, the bleb from trabeculectomy surgery, or they may even notice a little white patch of donor graft if you've had tube surgery. You might need to peer for this one. If you've had stent put in under the top eyelid, you may notice a thin yellowish line, and that's the stent in place. And if you have a distorted pupil, again, that's evidencing post-surgery for a drainage device implant to treat your glaucoma. So photography can cover the front of the eye and the back of the eye to help put this jigsaw together. There's also a scan that can be done for the front and the back of the eye. These scans are fabulous because the clinician can not only see the changes with the scan, but they can do measurements, and particularly useful for looking at that front where the fluid is produced and where it drains. You can visualize that, you can measure the angle, and some of you this evening may have open angle glaucoma or closed angle glaucoma. So you can look at that angle, you can measure it, you can predict if someone is going to be prone to having like a closure episode. They're wonderful, these machines. They don't take long, as you know, but they give so much information. An OCT can also pick up evidence of some surgery that you've had, such as these 4 photos here. You'll be able to see the stent, the eye stent that you have had injected to help with the flow of the pressure of the fluid. The majority of these machines, though, will do photography and OCT. So you're looking and you're measuring and you're able to really have a look to see what is happening, what are the measurements showing you, etc. So they're a little bit hard to navigate, these maps. I'll do my best to quickly run through it with you. And depending on the instrument, the type of machine that your doctor has, the printouts will be a little bit different. So we have a coloured map there. It's called the RNFL thickness map. And that's just measuring how thick are those fibres that carry the information back to the brain. If there is thinning in that area, and you get thinning from damage, if there's thinning, it will be more blue. If it's slightly thicker, it will be yellow. And at the thickest point, it will be red. The little maps to the side that look like a clock hour or a pie chart, if it's green, that tends to be more within the normal range. If it's red, it's outside the normal range. So you've got the black and white photo with arrows on it pointing to an area of damage. You have the coloured thickness map with black arrows pointing to the same area. The deviation map under that, again pointing to the same area. And the clock one with the red triangle, that's again marrying up the same area. This image is of another OCT and photography machine, and again pointing out the changes that have occurred from the glaucoma. The top section, it's a bit hard to see, it's showing some change in the blood vessels. And the lower ones, the coloured ones, are showing the red abnormal or defective areas, which marries up to where the blood vessel has changed. So the circular map is showing the defect, and the graph map again is showing that same defect. So everything does marry up. It's putting that jigsaw together. So moving on, and I know that with glaucoma, it's mainly those numbers that people tend to flow around. And the normal range is between 10 and 21. However, there's a lot of influence around that. So it can be the position that you're holding during the measurement. You might have a thicker cornea, the front surface of the eye. Your cornea might be a bit wider or more curved. It might be more rigid, so less flexible. There might be some scarring, or it might be a bit dehydrated. That can all influence the number that you have. And the eye pressure number is gained by the force required to gently flatten a fixed area on the corner. That's how you get that number. Now, the usual way that an ophthalmologist will measure is by popping your chin on the chin rest, forehead against the bar, and he will gently rest a little device on your eye. That's called the Goldman. If you have it done with an optometrist more so, it might be the puff of air, where the small puff of air is measuring that resistance. Or you may have the handheld instrument called an eye care. Both ophthalmologists and optometrists tend to use that one. And it's a little probe that rebounds on the surface of the cornea, again, to measure that pressure resistance. It's commonly known that there is a difference between some of these measuring intraocular pressure measuring instruments. The eye care and the air puff one may be up to 3 millimeters of mercury lower than the Goldman one. However, there's always an exception to the rule. The eye care might end up being a higher measurement if your pressure is already sky high. Then they would recheck that with the gold standard Goldman. So yes, there is variation, but the main thing is whoever you go to will be measuring with the same instrument, and that's what your benchmark is. And if you get peaks and high ranges from that benchmark, that's what they will pick up. So there's no right or wrong instrument to measure the pressure, but we do know there will be a variance in benchmark for each of those. And then there's the dreaded visual fields, the dreaded flashing light test. No one enjoys doing this test, and including the orthoptist who's doing it, especially if they've done 10 in a row, having done that many times. The reason that they want you to do the visual field test is to map out your side vision, and we know that glaucoma affects the peripheral or the side vision first. You don't really notice that because every time you look at something, you're not using your side vision, you're using your straight ahead vision. So if your side vision is having those changes, you won't really know because you're not using that part of your eye. Again, there are hallmarks in a visual field response that are typical of glaucoma and not other diseases. So the visual field test will point these out, and I'll show you some examples of those as we go on. In a normal visual field, which we've got there on the left, there is a darker area on the right of that map. It's black because there are no little seeing cells there. You can't see anything in that area, and that's literally your blind spot. So it will turn out to be darker squares or darker dots on that printout. And that just means that a brighter light is needed to be seen at a darker spot. And I'll show you examples of that. So you've had all of these tests done. The doctors looked at what they want to look at. Everything's done. You're exhausted. You've had enough. But let's just put them all together. What does it mean? So we've got the photo. And in this particular photo, you'll see that we're going to look at the disc and the cup. Everything looks a good ratio. The cup's in a good shape. There's no vertical elongation there. The donut is of a good color. The blood vessels aren't veering off course, or there's no kinks in them. There's no hemorrhages. The visual field looks good. The dark bits are dark where they should be, just around the blind spot. The color map, the color codes are as they should be, and the gray central areas are the optic disc and the cup. And again, that's mirroring that really good ratio. And the black and white ones are showing the horizontal, the black and white ones of the correct diameters as well. If you have early glaucoma though, you will start to see changes in the photo. It's a bit hard to see at the top of the donut. There's some color change there. The visual field has some darker areas, and they're sort of coming in. That's what we call a nasal step, very typical of glaucoma. The colour map, it's starting to change a little bit more, and the middle light grey centre, the cup, it's grown a little bit as well. And the black and white photos, they're starting to change a little bit in shape, a little bit square where it's dipping down. If the glaucoma progresses more, again, joining the jigsaws, we see that there's more elongation, in the optic disc. So the colour photo, there are more changes. There are more changes in the visual field. The colour map, there's not much left except for blue. And the black and white one is getting even deeper and more excavated. And with advanced glaucoma, that colour photo, it's the donut is now black. The visual field, there's a lot more black. The black has progressed to your central vision. With the colour map, virtually blue, and you can't even see the extent in the black and white scan because of that extra progression and the damage that's been done to those nerve fibres. So glaucoma really is a jigsaw. It's not one test or the other test. Everything needs to be put together. That's why they do all of the tests. They are annoying. They're the duration. I know that you get very anxious. I've done them myself, and yes, I too get anxious at all of them because you don't want to muck it up, and that gets you even more anxious. But the doctor has your benchmark there. They know what is your normal, and they can map the progression by repeating everything every visit. They can map the progression, put it together to then develop a treatment plan for you. With our SightWise program, we really work well with people who are suspects or confirmed with glaucoma, because we've learnt from experience and time that early support, treatment compliance, and appointment adherence will help hopefully lead to extreme vision loss because of glaucoma damage. Thank you for your time.
Val, I continue to learn more every day, even despite your excellent tutelage of me so far. Firstly, thank you for your insights, and absolutely, again, I'm sure on behalf of the community, for the passion of which you display in supporting our community. There are a couple of questions that have come from the community, if you'd be so kind to potentially answer them. So let me read them out for you. The first one is, Val, the tests that I have were all done at the optometrist, who then referred me to the ophthalmologist. Why did I need to have them repeated and pay again at the doctor's?
And that's a fabulous question, and quite a common question. And it is a frustration. Each clinician likes to have their own baseline measurements on their own machine, and then they can get the machine to work out the subtle changes that may have taken place between your visits. So from visit A to visit B to visit C, the machine can compare all of those results and mark out any subtle changes. And it's also a way of validating what another practitioner may or may not have said. If you were to simply take your results, your printout, to the second doctor, the second person, it's going to be inaccurate if they sit there trying to count the number of, for example, on your visual field, the number of dark squares that might be there compared to last time. So it's creating a benchmark, and it's validating what the previous person has thought. But great question.
Thank you. Second question, Val, are there any new or emerging tests for glaucoma that show promise for early detection or better monitoring? And as a follow-up, how do these newer tests compare to traditional methods in terms of accuracy and reliability?
Yeah, thanks, Adam. We know that there's always tests emerging. One of the tests that we have had mentioned from our glaucoma community is the genetic testing to estimate a person's genetic risk of developing primary open-angle glaucoma or the risk of current glaucoma progression. Glaucoma Australia is very supportive, as you know, of this clinical research. However, we're not, as you know, involved in administering any of these tests, but that's just one example of an emerging test to try and predict what might happen. There's also changes in the instruments that are used. For example, the OCT, the scanning one, they're being refined more and more for better clarity of images. You can look at deeper layers of the back of the eye for early markers. So you'll get those markers earlier for glaucoma, such as with the blood vessels or the retinal cells. For the follow-up question, how do they compare? The instruments currently being used are far more advanced than those being used even 20 years ago. They're still reliable, they're still accurate, and it tends to be the glaucoma specialists who deal in the trickier glaucoma that would be venturing into using these more specialised instruments. So they're still accurate and reliable, but you tend to find the fancier ones with the fancier glaucoma doctors.
Modern technology, hey?
Yeah, yeah.
Another question around tonometry. So Val, what's the value in at-home or self-tonometry? Should I be doing this to monitor my eye pressure between appointments? And as a follow-up, again, how reliable are these tests and can they replace visits altogether?
Yeah. We do get asked that a fair bit with people who are ringing for site-wise support. I guess there are pros and cons. It's great for using at home if you're perhaps in a more remote area, or if you're not well, if you can't attend your appointments, etc. And they do give great peace of mind and allay any mental health issues that might be surrounding your glaucoma diagnosis. They send the information to the ophthalmologist, who can then modify appointments if they need to. Some of the cons are, we do know that everyone has pressure spikes throughout the day, and some of the activities that you've been doing, such as yoga or a massage with your head face down, etc., you're going to get a rise in pressure. So you do need to be mindful when you are doing the at-home self-monitoring. They're very reliable for monitoring, but I wouldn't be using them for your own self-assessment of your treatment regime. You shouldn't replace them with going to your appointments. You still need to go to your appointments, see the ophthalmologist, because remember, pressure is only one part of the glaucoma jigsaw. So you can monitor your pressure, but it's only one part of that jigsaw.
Great response. So complementary to your regular appointments and your ongoing appointments, which certainly we at Glaucoma Australia strongly advocate that our community should comply with. A couple of more questions, just mindful of the time for everybody. Val, what are the possible side effects or discomforts associated with glaucoma testing?
Yeah. Apart from having an empty wallet when you leave the ophthalmologist, you may, some of the eye drops that they put in, you might have the dilating drops because they might just need to check the back of your eye periodically with a bigger pupil to see through. So that's going to cause discomfort and glare and blurred vision for a couple of hours. Or they may put the numbing drops in to check your pressure, and that might be a little bit uncomfortable as well. I guess fatigue and anxiety of having to do this whole lot of batch of tests every 3 months, 6 months, whatever it is. So they would be the main side effects.
Okay, excellent. And then maybe one final question, and we do have other questions that we've received, which we will of course respond to post the Q&A. The final question, Val, is: I am a glaucoma suspect. How often should I be getting tested for glaucoma?
Brilliant question. It depends on the clinician, but they no longer than 12 months. So between 6 and 12 months is ideal. And we urge optometrists to refer to Glaucoma Australia even at the suspect stage, because we can explain what suspect means, we can explain what the next steps might be, and we can allay all of that distress and anxiety that comes with the final diagnosis of glaucoma. We have the resources, we have the time, but within the clinics, the clinician and his team, they don't have the time to explain. But 6 to 12 months if you're a suspect.
Thank you very much. Well, we might wrap the questions there. Val, again, thank you for your insights tonight, for sharing with our community around this very, very important topic matter, and of course for your passion. I will of course see you bright and early at work tomorrow.
Yes, boss.
I'd also like to take the opportunity as we wrap up to thank our sponsor again, Glaucoma, for their unwavering, very generous support of our live Q&As. And for our registrants tonight, we will send a follow-up email which will have a link to our site-wise, and we strongly encourage you to participate on that. You can see a banner that's popped up on the screen now, so we will follow you up with that. Please register. And for those of you who are supporters of ours, and many of you are, thank you again for everything you're doing for us. Glaucoma Australia is 100% community funded, and we very much value and appreciate the support that you give us. So until next time, stay safe and take care, and thank you.
Thank you.